Place two fingertips against your cheekbones, just below your eyes. Press gently and hum a single note for 10 seconds. Hold the pressure. Notice that the vibration you feel is not coming from your throat. It is arriving through the bone under your fingers from hollow chambers inside your face that most people have never consciously located. Those chambers are doing something to the air they contain right now, and what they are doing with that air connects a 10-second hum to the diameter of blood vessels inside your lungs before the note ends. Keep your fingers there. The explanation begins with the architecture. Your skull is not solid. Carved into the facial bones and the anterior cranial base are four bilateral pairs of air-filled cavities, collectively called the paranasal sinuses, and each pair occupies a distinct anatomical address. The maxillary sinuses sit directly behind your cheekbones, the largest of the four pairs, roughly pyramidal in shape, with a combined internal volume in adults of approximately 30 to 35 milliliters. Your fingertips are resting against their lateral walls right now. The frontal sinuses occupy the bone above your eyebrows, separated from each other by a bony intersinus septum, variable in position from person to person, sometimes so asymmetric that one frontal sinus is twice the volume of the other. The ethmoid sinuses are not a single cavity, but a labyrinth of 8 to 15 small air cells clustered between the orbits, their paper-thin lateral wall called the lamina papyracea forming the medial boundary of each eye socket. The sphenoid sinuses lie deepest, excavated into the body of the sphenoid bone at the geometric center of the skull, bordered superiorly by the pituitary fossa and laterally by the cavernous sinuses carrying the internal carotid arteries. Every one of these cavities is lined with pseudostratified ciliated columnar epithelium, the same mucosal tissue type that lines your nasal passages, and every one of them communicates with the nasal cavity through a narrow exit called an ostium, a tubular opening typically 1 to 5 millimeters in internal diameter, depending on the sinus and the individual. The ostium is not a defect in the design, it is the design. A narrow neck connecting an enclosed air volume to the outside is the defining geometry of a Helmholtz resonator, a class of acoustic device described by physicist Hermann von Helmholtz in 1860, in which the volume of trapped air and the dimensions of the neck together determine a resonant frequency at which the air column oscillates with maximum amplitude when driven by an external vibration at or near that frequency. Your four sinus pairs are not shaped like Helmholtz resonators by coincidence. They are Helmholtz resonators. The physics is not a metaphor. It is the governing equation. When you hum, your vocal folds, the two-paired mucous membrane-covered ligaments stretched across your larynx between the thyroid and arytenoid cartilages, are drawn together by the lateral cricoarytenoid and interarytenoid muscles and held in the phonation position so that exhaled air drives them into rapid oscillation. At a comfortable mid-range hum, that oscillation frequency sits between 100 and 300 Hz, depending on the individual's vocal anatomy. The vibrating folds set the thyroid cartilage oscillating. The thyroid cartilage transmits vibration through the cricoid cartilage into the hyoid bone, and from the hyoid, the vibration enters the mandible. From the mandible, it propagates into the temporal bones flanking the skull, and from the temporal bones, it spreads through the entire cranial vault simultaneously. Bone conducts vibration at approximately 3,200 meters per second in compact cortical bone, between 8 and 10 times faster than sound travels through air at the same temperature, which means the vibration that began at your vocal folds reaches the posterior wall of your sphenoid sinus at the center of your skull in under a millisecond. The skull does not muffle this vibration, it distributes it. Every sinus cavity embedded in the vibrating bone receives the mechanical input from its bony walls simultaneously, and each cavity whose resonant frequency matches or approaches the frequency of the hum responds with internal air oscillation at elevated amplitude. This is acoustic resonance, and its consequences for the gas inside the sinus are the first mechanism. The mucosal lining of each sinus cavity, including the epithelial cells, the submucosal glands, and the microvascular endothelium, continuously synthesizes nitric oxide through the enzyme endothelial nitric oxide synthase and inducible nitric oxide synthase, which catalyze the conversion of the amino acid L-arginine to L-citrulline with nitric oxide as the other product. Nitric oxide is a diatomic gas, Molecular formula NO, with a half-life in biological tissue of 2 to 30 seconds, depending on local redox conditions. Under quiet breathing, the NO produced inside the sinus cavities diffuses passively through the ostia at the slow rate that passive diffusion through a 1 to 5 millimeter opening permits. The gas accumulates between diffusion cycles, and only a small fraction of what the epithelium produces reaches the nasal airway with each breath. Eddie Weitzberg and John Lundberg at the Karolinska Institute in Stockholm measured nasal nitric oxide during humming versus quiet nasal breathing and reported a 15-fold increase from a baseline of approximately 0.2 parts per million in exhaled nasal air to approximately 3.0 parts per million during sustained humming, published in the American Journal of Respiratory and Critical Care Medicine in 2002. 15-fold. Not 15%, not a doubling, not a tripling, a multiplication by 15. That number is worth sitting with because it means that the sinus epithelium was not producing 15 times more nitric oxide during humming. The epithelial production rate is relatively constant. What changed by a factor of 15 was the delivery rate, the rate at which the gas accumulated inside the sinuses was flushed out through the ostia into the nasal airway. The mechanism driving the delivery change is acoustic pumping. Resonant oscillation of the air column inside the sinus during humming creates rhythmic pressure differentials across the ostium. Momentary pressure increases inside the cavity, followed by momentary pressure decreases, each cycle pushing a bolus of NO-enriched air out through the narrow opening and drawing fresh air back in. The narrow ostium that limits passive diffusion becomes the nozzle of an acoustic pump when the air column it connects is resonating. Frequency determines pumping rate. The rate of pressure oscillation determines how many flush cycles occur per second, and therefore how much accumulated nitric oxide exits the sinus per unit time, which is why Weitzberg and Lundberg also found that humming frequency influenced the magnitude of the effect, and why a mid-range sustained hum, producing frequencies close to the resonant frequencies of the maxillary sinuses, delivers more NO to the airway than a very low or very high hum that couples less efficiently with the sinus geometry. The 15-fold figure is the engineering fact. The acoustic pump is the mechanism. The sinuses were producing the gas continuously. The hum released it. Once that NO-enriched air has been flushed into the nasal cavity, it travels with the next inhalation down the nasopharynx, through the larynx, past the carina, and into the bronchial tree, reaching the alveolar surface where gas exchange occurs. At the pulmonary vasculature, nitric oxide crosses the thin alveolar capillary membrane and enters the smooth muscle cells of the pulmonary arterioles. Inside those cells, it activates soluble guanylate cyclase, the enzyme that converts guanosine triphosphate to cyclic guanosine monophosphate. The elevated cyclic GMP activates protein kinase G, which phosphorylates myosin light chain kinase, reducing its activity, reducing myosin-actin crossbridge formation in the smooth muscle, and producing relaxation of the arteriolar wall. Relaxation of the arteriolar wall is vasodilation. The pulmonary arterioles widen. The resistance to blood flow through the pulmonary circuit decreases. More capillary surface area comes into apposition with the alveolar membrane. More alveolar capillary contact area means more diffusion surface for oxygen transfer, which means more oxygen crossing into the blood per breath at the same inspired oxygen concentration. This is the identical molecular pathway, the same enzyme, the same second messenger, the same smooth muscle target, the same vasodilatory endpoint, activated by sildenafil, tadalafil, and the class of phosphodiesterase 5 inhibitors that generated approximately $4.5 billion in annual global pharmaceutical revenue as of 2023, and activated by inhaled nitric oxide therapy, the medical gas delivery system used in neonatal intensive care units for pulmonary hypertension of the newborn, which requires compressed gas cylinders at concentrations of 20 to 80 parts per million, precision flow blending equipment, continuous electrochemical NO and NO2 monitoring, and a trained respiratory therapist. The molecule your sinus epithelium synthesized and the acoustic pump delivered to your alveoli is the same molecule. The concentration is different, the route of delivery is different, and the clinical context is entirely different. Nobody is suggesting that humming replaces inhaled NO therapy for a 36-week neonate with persistent pulmonary hypertension. That application requires precision dosing, continuous monitoring, and clinical oversight for reasons that are serious and non-negotiable. The biological version is a low-dose, self-administered, mechanically delivered pulse of the same vasoactive molecule, arriving at the pulmonary vasculature through the body's own sinus architecture, rather than through a cylinder and a blending manifold. The pathway is not analogous to the pharmaceutical mechanism. It is the pharmaceutical mechanism. The dose is the variable. The anatomy delivers it at no cost at your kitchen table through the acoustic properties of bony chambers your skull contains by default. While nitric oxide is doing its work at the alveolar membrane, the same vibration that drove the sinus resonance is propagating through the temporal bone and encountering the vagus nerve along two separate anatomical routes simultaneously. The vagus nerve, the 10th cranial nerve, exits the brainstem through the jugular foramen of the temporal bone, descends through the carotid sheath alongside the internal and then common carotid artery, passes directly lateral to the larynx, separated from the vibrating thyroid cartilage by only a few millimeters of loose areolar connective tissue, and continues into the thorax and abdomen. At the laryngeal level, sustained vocal fold vibration during humming transmits mechanical energy through those intervening millimeters of tissue to the nerve's outer connective tissue sheath, the epineurium, mechanically deforming the axonal membranes of vagal afferent fibers. Mechanosensitive ion channels in those membranes, including piezo 1 and piezo 2 channels that open in response to membrane stretch, transduce the mechanical deformation into electrochemical signals that propagate toward the brainstem along afferent vagal fibers. The nerve is being physically shaken. The shaking opens ion channels. The ion channels generate afferent traffic. The brainstem nucleus that receives that traffic, the nucleus tractus solitarius in the medulla, responds by increasing parasympathetic outflow through the vagus and inhibiting sympathetic outflow from the intermediolateral cell column of the thoracic spinal cord. Heart rate falls, not dramatically. In studies of vagal tone during sustained vocalization, the parasympathetic shift typically produces a reduction of 2 to 5 beats per minute, detectable within 15 to 20 seconds of onset. Heart rate variability, the beat-to-beat variation in the cardiac cycle interval that serves as a proxy measure for vagal tone, increases measurably. The second route from bone to vagus runs through the temporal bone itself. The vagus passes through the jugular foramen, where the temporal bone meets the occipital bone, and the temporal bone is transmitting vibration from the vocal apparatus through the mandible during the entire hum. The nerve's intracranial course is embedded in bone that is vibrating. Whether this second mechanical input produces additive vagal activation or merely reinforces the first has not been measured in isolation. The anatomy supports a dual delivery. The direct measurement has not been done. Simultaneously with both vagal pathways, the mechanics of humming are imposing an exhalation to inhalation ratio on the breathing cycle that the person performing it did not choose and does not need to count or maintain. Humming occurs only during exhalation. The vocal folds require exhaled airflow to sustain oscillation. Inhaled airflow moves in the opposite direction through the larynx, past the folds rather than through the phonation gap, and produces no sustained vibration. The moment inhalation begins, the hum stops. The moment exhalation resumes, the hum restarts. A person humming a sustained note through a comfortable exhalation and then breathing in before returning to the note is producing an exhalation phase lasting 8 to 12 seconds and an inhalation phase lasting 2 to 3 seconds without counting, without following a protocol, without any instruction beyond hum a note. The resulting exhalation to inhalation ratio of approximately 3 to 1 to 4 to 1 is the target ratio of nearly every clinical slow breathing protocol in the autonomic literature. Box breathing attempts it. Resonance frequency breathing at 0.1 Hz attempts it. Extended exhale protocols in anxiety management attempt it. They require instruction. They require a count. They require sustained attention over days to weeks before the pattern becomes automatic. Humming does not require any of those things. The vocal fold mechanics enforce the ratio as a physical consequence of how phonation works. During the extended exhalation, intrathoracic pressure rises slightly, cardiac output decreases momentarily, and the baroreceptors in the aortic arch and the carotid sinus, pressure-sensitive stretch receptors that monitor arterial wall distension, detect the associated blood pressure fluctuation and send afferent signals through the glossopharyngeal and vagus nerves to the nucleus tractus solitarius. The baroreflex response shifts autonomic balance toward parasympathetic dominance, slowing the heart rate through the same nucleus that the mechanical vagal stimulation from laryngeal vibration is already activating. Two independent afferent pathways, the mechanical vibration pathway and the baroreflex pathway, converge on the same brainstem nucleus, the same parasympathetic output, the same cardiac deceleration during the same 60-second hum. Neither pathway alone produces the combined effect. The convergence is not additive in a simple arithmetic sense because both pathways involve nonlinear neuromodulatory networks in the brainstem, but the person activating both simultaneously is producing a parasympathetic shift of greater magnitude and shorter latency than either pathway would produce in isolation. The person over 60 who was advised to try relaxation techniques and found them difficult to execute because they require sustained attention, counting, or a mental state that does not come on demand, has in a 60-second hum a physiological intervention that works through physics rather than through psychology. The vagus does not require the person to feel relaxed in order to respond to mechanical vibration at the larynx. It requires vibration. The baroreflex does not require the person to intend a particular breathing ratio. It requires the pressure change that the extended exhalation produces. Both arrive automatically from the hum. A fifth mechanism operates deeper in the skull, and the evidence for it sits on a different evidentiary shelf than the nitric oxide data or the vagal data, so its description requires that distinction to be stated explicitly before the mechanism is described. During humming, the partially adducted vocal folds and the closed mouth create a mild increase in airway resistance during exhalation, elevating intrathoracic pressure slightly above what open mouth exhalation produces. That pressure elevation transmits through the thoracic veins, through the superior vena cava, through the internal jugular veins, through the jugular foramen, and into the intracranial venous sinuses, the dural venous sinuses lining the inner surface of the cranial vault. The connection between thoracic and intracranial venous pressure is a direct hydraulic one. Pressure changes in the chest propagate to the intracranial space within fractions of a second. The result is a low-amplitude rhythmic oscillation of intracranial pressure synchronized with the humming frequency. Cerebrospinal fluid, the clear fluid manufactured by the choroid plexus in the cerebral ventricles, circulating through the ventricular system and the subarachnoid space, bathing the outer surfaces of the brain and spinal cord, moves in response to these intracranial pressure changes. CSF pulsatility, driven by respiratory mechanics, has been documented. Marek Czosnica and colleagues at Cambridge, working on intracranial pressure dynamics, have characterized the respiratory component of CSF flow as a meaningful contributor to overall fluid movement, distinct from the cardiac pulsatility component. That humming specifically amplifies the respiratory component of CSF pulsatility through the added airway resistance of the partially adducted folds, is mechanically consistent with the documented hydraulics, and has been proposed but not directly measured with the intracranial pressure monitoring methodology that would confirm it. The connection between amplified CSF pulsatility and glymphatic clearance, the perivascular waste clearance mechanism described in detail by Mike and Nedergaard's group at the University of Rochester in 2013, in which CSF flows along periarterial spaces, exchanges with interstitial fluid, and drains along perivenous pathways carrying metabolic solutes, including amyloid beta and tau, out of the brain parenchyma, adds a further inferential step. Increased CSF pulsatility logically facilitates perivascular flow. Whether a 60-second hum produces CSF pulsatility changes of sufficient amplitude to meaningfully enhance glymphatic throughput has not been directly measured. The physics supports a connection. The direct evidence does not yet exist. This is the mechanism on the most preliminary shelf, physically consistent and anatomically grounded but not confirmed, and the viewer should hold it differently than the 15-fold nitric oxide increase, which was measured directly, or the exhalation to inhalation ratio, which is determined by the mechanics of phonation and requires no measurement to confirm. The evidence calibration across all 5 mechanisms is as follows. The 15-fold increase in nasal nitric oxide, the vasodilatory molecular pathway at the pulmonary vasculature, the mechanical vagal stimulation at the larynx, and the enforced exhalation-dominant breathing ratio are established, replicated, or mechanically certain. The baroreflex contribution during extended exhalation is established physiology applied to humming by straightforward inference from documented autonomic mechanics. The intracranial pressure oscillation pathway is physically plausible and consistent with documented hydraulics, but not directly measured during humming. The glymphatic enhancement inference adds a second inferential step beyond that and sits furthest from confirmed measurement. The drama of humming is not in the weakest mechanism, it is in the convergence of the confirmed ones. The fingertips you placed against your cheekbones at the start of this felt the maxillary sinus walls vibrating. That vibration was the acoustic pump that produced the 15-fold nitric oxide increase Weitzberg and Lundberg measured, flushing a vasodilatory molecule from bony production chambers in your face into your pulmonary vasculature. Simultaneously, the temporal bone was transmitting vibration to the vagus nerve at the jugular foramen and through the millimeters of tissue separating the nerve from the oscillating thyroid cartilage. Simultaneously, the closed-mouth phonation mechanics were enforcing an exhalation to inhalation ratio that clinical breathing protocols spend weeks training automatically as a physical consequence of how the vocal folds work. 3 confirmed mechanisms, running in parallel, requiring nothing but a closed mouth and a note. An entire industry built a delivery system for the molecule your sinuses manufactured during that 10 seconds at the start. Compressed cylinders, precision blending manifolds, electrochemical monitors, hospital-grade respiratory equipment. The delivery system you were born with is 4 pairs of Helmholtz resonators carved into the bone of your face, each one connected to your airway through a narrow ostium that becomes an acoustic pump nozzle when the vibration arrives through the skull. The molecule is ready. The chambers are filled. Close your mouth. The pump needs only a note.